Welcome, Dr. Patil.
All right, let's do a mic check. Can everyone hear me okay? All right, thank you. So I'm Tejas Patil, and I've been tasked with covering lung cancer in 20 minutes, so we'll see how this will go. These are my disclosures. These are the objectives. So basically, I'm going to give an overview of what I perceive as the biggest advances in lung cancer, largely immunotherapy, targeted therapy, and then we'll cover a little bit of where we think we're going. So this is a slide that everyone knows. Basically, the major risk factors for lung cancer continue to be cigarette smoking. And I like this diagram of the cigarette, which shows all the different carcinogenic compounds in cigarettes, and also where you're likely to see them in the cigarette itself. That being said, there's also environmental factors. So secondhand smoke is appreciated to be increasingly appreciated as a risk factor. We also see, and there was a really nice paper by Charles Swanton in Nature, it was front cover of Nature recently, that talked about the impacts of air pollution. And I'm really going to flag that. That I think is going to become an emerging risk factor that we have to pay attention to. There are also industrial exposures. These tend to be rare and fairly obvious. So when a patient says, I'm working in a plastic factory, okay, so that you have a clear exposure there. Biologic risk factors are kind of interesting. Genetics don't play as much of a role in lung cancer as you would see in other cancer subtypes like colorectal carcinoma or breast carcinoma. But what you do see is there is a very rare de novo T790M mutation that seems to be germline. And if you see that in a patient, you definitely want to screen them and their families for it. The other risk factors that I will highlight are solid organ transplantation. This is a major risk factor as we're doing more kidney transplants, bone marrow transplants. That being on chronic immunosuppression plays a role in increasing your risk for cancer, and it tends to be squamous carcinomas for what it's worth. Tuberculosis and the other one here, which I want to highlight at the bottom of this, is really the most important risk factor for lung cancer, especially since we've started screening patients more for lung cancer. The biggest risk factor is if you had a prior history of lung cancer, your risk is actually very high. So prior history of lung cancer, and I would actually extend that to smoking-related cancer. So if you had a prior head and neck cancer, your risk of a lung primary is also very high. Okay, this is the histology of cancer. I won't bore you, everyone here knows this. So non-small cell lung cancer is about 75%, small cells about 26%. And then this is the SEER data. This is a little bit outdated, it's from 2021, but I guarantee you 2023 will show the same statistics. Lung cancer is the leading cause of mortality in both men and women, and it's the second most common cause of cancer in both men and women in terms of incidence. So historically, chemotherapy was what we used to have and was all we had really to treat lung cancer. For small cell, platinum etoposide was the preferred regimen. For squamous, there were multiple therapies. You could use platinum taxane, and in Europe, they still do that. So carboplatin Taxol is actually a very common regimen for lung cancer. In adenocarcinomas, there's been an increasing move towards using platinum pemetrexed compounds. The preference for a platinum doublet is shown here in this meta-analysis that clearly shows that if you look at the hazard ratio, there's a slight preference for chemotherapy. It's also shown here. And then I want to show this slide. This is a very nice paper that did a meta-analysis of multiple different clinical trials. And while it does show a benefit for chemotherapy, I have to be honest, this was a pretty disappointing result. So the 1-year overall survival was, and again, I'm having a hard time seeing this here, so I'm just going to look over it, was 29% versus 20%. So we really did not move the needle with chemotherapy. And this was kind of where we were in about 2004 for lung cancer. So what's changed? Two things have changed. Immunotherapy has changed. So the history of cancer immunotherapy is not new. Paul Ehrlich first conceived that tumor cells can be recognized as foreign and eliminated by the immune system. And then Sir McFarland Burnett, he actually won the Nobel Prize for this. He formalized this concept of something called immune surveillance. And so the idea is not that your cancer forms and then your immune system recognizes it, your immune system actually plays an active role in keeping cancer from forming. So with a healthy immune system, in principle, you don't form cancers. Now, it's more complicated than that, obviously, but there's this observation that I mentioned earlier that one of the biggest risk factors for lung cancer is a history of immunosuppression. So HIV, AIDS, or solid organ transplant have almost a 10 to 100 times fold risk of lung cancer than the general public. Different strategies for immunotherapy. We say immunotherapy doesn't mean Keytruda or pembrolizumab or Tecentriq. So there's a lot of things that fall into this category. Non-specific things include using bacterial extracts. So the BCG vaccine that they use for early stage urothelial carcinoma is actually what you would use for tuberculosis. And it happens to be the case that the BCG protein induces a non-specific immune activation locoregionally in the bladder. There's cytokine activation. We don't do this as much with the era of immune checkpoint inhibitors, but IL-2 therapy used to be used in melanoma and renal cell carcinoma. TNF-alpha inhibitors used to be used in oncology. We've moved away from them. They're actually making a comeback in rheumatology, where you're seeing drugs like Enbrel being used, and then interferon therapy. Specific immunotherapies where you have antigen-specific responses. So we don't think of rituximab as immunotherapy, but it really is. It's a specific monoclonal antibody for CD20 on the B cell. Tumor-infiltrating lymphocytes, so this has really been making waves in heme malignancies with CAR T-cell therapy, tumor vaccines, and then finally immune checkpoint inhibitors. And so very briefly, again, most of the audience here will know this, but the way immune checkpoint inhibitors work is that you normally have a toll-like receptor, TCR, that binds with an MHC, and that triggers a signal 1. Now, there is a checkpoint that is built into your body that regulates that interaction, because normally that would be an activated T cell that would kill the antigen-presenting cell, in this case a tumor cell. So tumors evolve this ability to upregulate PD-L1. And the upregulation of PD-L1 is what we think allows cancer cells to escape immune detection. And these are actually where the drugs bind. So they can either bind on the tumor cell, which is where you have PD-L1 inhibitors like atezolizumab, or they can bind on PD-1, which is pembrolizumab or nivolumab. And the point of all of this is really to show that this stuff works. So this is the data from the Keynote-24. This is 5-year overall survival, and I really want to flag this data here. Notice that the tail of the curve. About 30 to 40% of patients are living 5 years after a diagnosis of stage 4 lung cancer, and this was in PD-L1 high, so PD-L1 greater than 50%. And this is significantly better than where we were with the era of chemotherapy. So we've come a long way with immunotherapy. We have a lot to learn. These are select immunotherapy trials for your reference that have looked at a variety of chemo options. So there's not just pembrolizumab, there's also atezolizumab, there's ipi-nivo, and I've summarized them here. So what do these therapies do? Well, any kind of itis will happen, essentially, but some are more common than others. So actually what we see in practice is thyroid abnormalities occur in about 30% of patients. That's probably the most common adverse effect we see with immunotherapy. The ones that we get really scared about are colitis and pneumonitis, and those frequently require high-dose steroids. What's interesting is that these itises don't tend to happen at the same time. They tend to occur at different time points based on initiation. The key point here is they're not going to happen about a week after you start therapy. So the minimum time to see any kind of immunitis is going to be about 4 weeks. And they do vary. And this graph, I think this is a really nice paper that looks at different immune-related adverse events and when they occur. I want to highlight nephritis because this is a common problem we see in patients who are receiving pembrolizumab maintenance therapy after they've received their induction with platinum doublet. Okay, so let's pivot to targeted therapies. So in the past 15 years, the field of thoracic oncology has experienced rapid growth in precision oncology, and really what the key thing here is we've identified numerous driver oncogenes. And what I mean by a driver oncogene is I mean that this patient has a somatic alteration that we think in effect drives cancer growth. It's not that other cancer alterations aren't present. So it's very common to see a TP53 mutation. It's very common to see an RB1 loss. et cetera, et cetera. But we don't think TP53 is driving the cancer. It's not something that if you were to block it would necessarily stop cancer growth. This pie chart shows the distribution in the early stage and metastatic stage of different oncogenes in non-small cell lung cancer. And what's important here is that about 45% of mutations in the early and metastatic setting are currently targetable with either tyrosine kinase inhibitors, so these are small molecule inhibitors, or monoclonal antibodies in 2023. And so why does this matter? I want to pull back the SEER data set that I showed you earlier. So let's just do some math. If we take the incidence of lung cancer, there's 235,760 cases of lung cancer. This was in 2021. And if you grant that about 26% of these will be small cell, for which their molecular pathways are very different, you're left with 198,038 cases of non-small cell lung cancer, and of which if 45% of them will have some kind of oncogenic driver, that's 88,424 cases of non-small cell lung cancer with a driver oncogene. And to put that in perspective, this is the number of cases of pancreas cancer that's diagnosed every year. So oncogene-driven lung cancer is very common. Why do we care about this? Well, I want to highlight the importance of biomarkers. This is a seminal study on the left by Shepard et al. This was done in 2005. What they did was they took erlotinib and compared it to placebo. This was back in the day when there was really no effective standard of care in the third-line setting for non-small cell lung cancer. And what you noticed here is that the median survival favored erlotinib. I want to highlight this was a completely unselected population, and erlotinib is an EGFR TKI, right? But at the reason I'm saying this is at the time they didn't know that. They didn't know that they were selecting out a patient population in this data set. So this is unselected, and you'll see that there's a 1-year survival difference, and there's an 8% objective response rate difference. So this was kind of intriguing data. But what really drove this home was the separate study. This is the IPASS study later with Tony Mock as the senior author. And you see here is if you pre-select patients, if you actually look for if they are EGFR mutation positive or negative, and then you give them a targeted therapy, it turns out no-brainer, the patients who have the EGFR mutation do better. And that's what's shown up here on the top right. And if they don't have the mutation, they do much worse, and that's what's shown on the bottom left. Why does this also matter? Well, targeted therapies do have a higher quality of life than chemotherapy. This was a quality of life analysis from the Optimal study that showed a strong benefit towards erlotinib versus standard of care or chemotherapy in this setting. Let's briefly talk about some of the toxicities associated with TKIs. So, depending on where these drugs hit, you can get a variety of different adverse events. I've just shown in this slide a couple of the adverse events that you may see depending on the mechanism of action of the targeted therapy. With EGFR toxicities, these are very common. This is a maculopapular rash that you see with drugs. It's more common with first-generation EGFR inhibitors such as erlotinib than it is with osimertinib. On the right, you see what's very problematic side effect, and it's especially bad here in Colorado given how dry the environment is. But what happens is you get significant drying of the fingertips, which then leads to fissures and cracking. And as you can imagine, for patients who are working, needing to type, this is going to be a major problem. For ALK inhibitors, the ALK's another oncogene in non-small cell lung cancer. I've just put in this table a summary of the different side effects. I do want to highlight that the field as a whole has moved more towards using alectinib, brigatinib, and lorlatinib, specifically alectinib and lorlatinib. Lorlatinib is unique here. It has some very specific side effects. Almost everyone is going to have to be on some kind of statin with lorlatinib. It causes elevated lipid levels. And it has this very unique neurotoxicity profile, which has been a major issue with the drug. That being said, it is manageable. All of these side effects are dose dependent. So if you see them, it doesn't mean you stop therapy. It means you hold drug, reduce to the next tolerable dose. BRAF/MEK is very common. This is also used in melanoma. This is an example of a rash. It's actually very distinct from the rash that you see with EGFR TKIs. And it tends to be, these actually tend to be raised. It's not well shown on this picture, but the other point I want to highlight here is that when you put patients on BRAF/MEK inhibitors, you really need to do careful skin monitoring. They actually have a higher risk of cutaneous squamous cell carcinoma lifelong while they're on these therapies. The MEK inhibition produces very severe fevers. These are fevers that go up to 104 sometimes, and so patients need to be counseled that this is not really neutropenic fever, this is actually MEK inhibition, which then can be treated with Tylenol. Again, the general point with TKIs as a whole is that these are all dose-dependent problems. So if you're having problems with the maximum dose, you do need to back off. This is peripheral edema that we see with MET inhibitors. So for patients with MET exon 14 skip mutations, we see things, we're using drugs like capmatinib or tepotinib, and they can get these peripheral edema that can be really, really challenging to manage. What I want to point out about the peripheral edema with MET inhibitors is they tend to be delayed. So this is kind of a unique side effect where it takes about 6 to 8 weeks to develop this. It tends to not be diuretic responsive. It may be dose responsive, but this is one of the biggest issues with these drugs is that they get incredible levels of edema. And it can also be periorbital. So it doesn't just have to be in the legs. It can be scrotal, periorbital. It's sort of generalized edema. Okay, so in the last 4 minutes, let's talk about where the field is going. So I strongly believe that this is actually going to be a very major part of the way we think about lung cancer, which is to look at the concept of minimal residual disease. So this paper by Chowdhury et al. From Stanford was a really important paper because it highlighted the importance of whether you can detect minimal residual disease post-surgery. So let me kind of walk you through it. So on the right here, these survival curves, what they're showing are stage 1 to 3A patients who underwent curative intent therapy with surgery. And then they took their tissue and did whole exome sequencing on it and generated a blood assay based on the 16 most probable clonal mutations that they could detect in the patient's tumor. So it's all patient-specific. This isn't like Guardant or Caris or Foundation where you're running gene panels on the blood. These are patient-derived blood assays. And what you can see here is if you can detect any of those clonal mutations that you found in the surgical specimen in the blood, that patient has micrometastatic disease. You just didn't see it. And that patient will relapse. And that is what you're seeing in these survival curves here on the right. And I think this will start to play a major role in monitoring for not just non-small cell lung cancer, but cancer in general. And there's going to be a lot of data presented at ASCO in a month on this topic. Acquired resistance to targeted therapies is a major issue. This is almost every patient, actually every patient on a targeted therapy at some point will progress, and they're going to progress in very predictable ways. So cancer is an evolutionary arms race, and the cancers are trying to figure out ways to adapt to targeted therapies, and they can either use what's called they can either develop tyrosine kinase domain mutations. So if you look at the figure on the left and you look at the far left, this is looking at EGFR specifically. The most common mutation historically used to be T790M, which is an on-target mutation in the tyrosine kinase domain pocket. We see less of that now that we're using osimertinib, and we're seeing C797S as a very common mutation. But the point being, the larger principle is that if you get mutations in the binding pocket or near the binding pocket, we call that on-target resistance. On the other side, you see what's called oncogenic kinase switch. I use the term bypass signaling, but that's essentially where the cancer cell starts to use non-oncogene driver pathways. Or, for example, in this situation here, we see a patient who has an EGFR mutation. EGFR is the dominant oncogenic driver, but the cancer starts to say, hey, I'm going to start using ERB3 or MET or AXL to survive. These are survival adaptations. And so the logical next question is, well, can we know what the mechanism is and then combine different treatments? So if you know you have an EGFR mutation and they develop a MET alteration, can we do an EGFR drug and a MET drug together? This is what we did in this patient. So this was a patient who had peritoneal carcinomatosis, who had MET amplification on their peritoneal biopsy and had tons of ascites, treated with the combination of, actually osimertinib and crizotinib with significant improvement in their peritoneal disease. This was actually just after 4 weeks of treatment. The other major advance is going to be an antibody drug conjugate. So can we give chemotherapy smarter? Basically, we look for an antibody, and it's linked to a payload. The payloads currently that are in the drugs that are most furthest along in development are drugs that are microtubule inhibitors, so they're very similar to taxanes or vinca alkaloids, or DNA damaging agents such as the topoisomerase inhibitors. This is a field that's going to rapidly explode. There's going to be a lot of data coming out at ASCO this year looking at this, specifically in the second-line setting for non-small cell lung cancer. And in the breast cancer space, this has already made headway. So many of you are probably familiar with TDM1, which is very commonly used in breast cancer, and this is a similar concept to this. Finally, I will say that immunotherapy future directions. My questions here are, how do we improve the benefit with immune checkpoint inhibitors? If you look at the top right there, that waterfall plot I think is a very important paper by Aguilar et al. That really shows that the patients who do really well with immunotherapy, it's not just greater than or equal to 50% PD-L1 score, it's the patients whose PD-L1 scores are greater than or equal to 90%. They tend to do the best with immunotherapy. So how do we enrich for patients to get the most benefit? Can we add other targets? So there's a lot of work looking at novel targets like TIGIT, LAG3. Can we target myeloid-derived suppressor cells? What about the use of chimeric antigen receptor or CAR T-cell therapy, TILs? So the field of immuno-oncology is exploding, and there's a lot of different ways. I always, when I give my talks to the fellows, say, if you remember nothing at all, everything I said is in one slide, so you can just come back here. This is how you take care of advanced non-small cell lung cancer in one slide. And this is the summary. So understand that immunotherapy, targeted therapies are major treatments for non-small cell lung cancer. I wanted to just have you appreciate some of the major side effects for the different drug therapies with a focus mostly on immunotherapy, targeted therapy. We didn't spend a lot of time on this, but I'm going to hammer this home. Every patient with non-small cell lung cancer needs to have broad-based molecular testing. It is unacceptable in 2023, in my opinion, to be doing IHCs and piecemeal RT-PCRs. You should be doing broad-based NGS testing on any patient, irrespective of smoking status. And the management of what you do when you find driver oncogenes or no driver oncogenes is shown below. And I hope to give you a flavor of where we're going with the field. So with that, thank you.